So basically what I want to start discussing is really just give you a bit of a framework, because sometimes I do think there is kind of an intertwine of concepts when we are speaking about value-based healthcare, and some of them are more related to, you know, efficiency improvements than rather really the value-based healthcare. And I think it's important for us to distinguish a couple of these concepts. But I would first really start to focus on the why are we pursuing value-based healthcare, and what was really the initial agenda, and what was the the experiments that we did in Portugal, but also across the Europe. So it's just a quick glimpse. So it's, as a keynote issue, we're not going very deep, but really really focus on the whys and how can we move forward. So I mean, when we ask why we are establishing this and asking for this concept of value-based healthcare, the key question, I think, is very obvious. We could really elaborate a lot in terms of the reason why. I think the key question is really about efficiency. We're having, healthcare systems all across the world are really struggling with resources and multiplication of activities. One possible explanation is really the aging of societies. But if we just take this aside, is actually quite good investment for us to see exactly what are we doing and trying to extract as much as value as possible from what we do provide in terms of services to patients. One of the there's one argument is when you look at healthcare inefficiencies, and there's many data which at least say that there is at least between slightly over 20% of there is over 20% of waste in the systems. And when you look a bit deeper, we can actually say we cannot pinpoint that specific inefficiency to one specific factor, but rather the combination of factors. So it's not just a problem with us resources or medicines, or it's a combination. It's the intervention mix which sometimes results in this inefficiency. The second one is really, and that's a classical example, when we compare internationally or even nationally between the outcomes variation from the same procedure, we can see, for instance, a 17-fold difference from the best to the worst hospitals in terms of post-operative sepsis, or a 5% fold difference in 30 days mortality in hospital. So there is huge variation. And outcomes variation is really one of the key arguments that we usually tend to, to address when we're speaking about value-based healthcare. There is something there which really says, depending on the place and depending on the country, and even sometimes within the country, depending on which hospital we go, we're going to get different outcomes. So these are the kind of the classical examples of reason why. But let me take you a bit, longer ago, and actually. This all ideas, it started really on using benchmarking as a tool for quality improvement. And actually the reference for the next speaker on DGS, it will basically actually help a lot on this discussion. Really, we started comparing things because we want to improve quality. And we started in the industrial sector. That's why most of the times these areas of quality improvement really stem from improvements in the traditional sectors. And actually, engineers are really a lot in these areas, trying to improve processes. And this was actually the starting point where one of the key leading inspirers of value-based healthcare, Mr. Porter, was looking into when we was looking into the so-called forces, is actually the value-based competition was really a key differentiation factor, for us to say why we should be benchmarking. Because if we compare ourselves, if we benchmark ourselves, we can improve. And this was imported into healthcare, but also I think because of this, I think it also imported one specific problem, which was we started comparing very different sets of indicators. And because healthcare produces a lot of indicators, most of the times we do tend to have a lot, and I actually participated in my personal life in a lot of initiatives, of benchmarking initiatives, where we were comparing very different things. The problem with this is that we lack one of the key points, which I think Michael Porter, which is really took us, and in his opening speech when he was here in Lisbon, was really there is so much information in healthcare. We don't have a scarcity of information. We don't have. We do have a lot of information to compare ourselves. The problem is we're lacking a common understanding of what is value for different stakeholders. So if you're going to ask around what is the specific value that we produce, you're going to get very different response depending if you're speaking with a doctor, we're speaking with a pharmacist, with a payer, with regulators. Everyone is probably looking into a very different perspective. And his key point was really, we should start focusing exactly on what matters to patients and what production matters, which is really outcomes. And then he took one step further, is, so we should align on a joint definition of outcomes. And he also look into what can we consider outcomes. So in terms of what we call a full cycle of care. This is also one of the difficulties that we have right now, is really defining for each individual disease area what is a complete cycle of care. But there's working going on this. So he proposed in his book Redefining Healthcare in 2008, really a point is we should first redefine value as starting from the patient, which I think it should be obvious, but it didn't come obvious for too long in healthcare. And actually, when he's proposed this, he's also proposed that we should start first benchmarking outcomes than rather processes. And it was one of the key points that really was very strict and very, emphasizing this idea is the first part that we should take a look into is really defining what is an outcome and start doing the improvements at that point. And then we can improve processes. But if the processes are wrong, I mean, if we start on the processes side, we can improve efficiency, but just improving efficiency not related with patients, which is kind of hard. So that's why he was really focused on this. The second element was really the costing part. We should also define the costs of delivering those outcomes, and that equation would really provide a better value and sustained financial viability for these healthcare cycles. This obviously is very theoretical, but there is a lot moving forward. So in this meeting I was mentioning you about, we did actually was one of the persons involved in inviting Professor Porter here. And there was a kind of a discussion with the Ministry of Health, and this probably is too busy, the slide, but my point was, we went into each individual set of recommendations in the macropolis. And the first one that was, consensual, even from the ministry side and the regulator side, was really, we should start really mandating a full assessment of the outcomes by patients, which tells us that it's bought into. I think conceptually, even at regulators and political level, people understood that the first job that we should be doing together as society is really to first measure the outcomes of patients. So that was the starting point for Portugal. Not strikingly, the majority of and this is my personal view, of the first pilots that started here were more focused in easier to measure processes, or less complex, so to say, not easy, but less complex, which were more the short-term acute care kind of projects. You would name it hip replacement, which was kind of kind of interventions where there is it's a short-term oriented in terms of there is a procedure, there is an hospital admission, an intervention, and a discharge. And this was quite, we could very easily or very directly define the cycle of care. And then the second question was, let's work with patients and scientific societies to define what were those outcomes. So essentially, there was this international collaborative effort under ISHOM to standardize a lot of these outcome definitions. I think up until now, there's at least 28 data sets right now, which are covered, which basically define the cycle of care and define what are the outcome measures to evaluate. But all in all, when you look in what happened since then and what are the benchmarkings which are in place, I would say that there are pilots ongoing. In Portugal, there is probably a couple, to say the least. There is one which really generated a lot of traction. This one is around ophthalmology, first in cataract surgery, and I do believe there is other initiatives under the ophthalmology banner. And this was done through basically a consortium between public and private. So there was public hospitals and also private hospitals which agreed to start competing on this in terms of benchmarking themselves across this specific reference and this outcome. And I think the key success factor for this was really a combination of actually leadership between the scientific and the medical community to endorse this, and also because this is probably one of the areas that we could potentially export in terms of best practice, and also attract business for Portugal in the medical tourism area. So this is a combination of factors which basically said this is an area for opportunity, and this is an area where everyone agrees that we should start. So this it also highlights one point: is just beyond the technical aspects, culture, leadership, and is also really a key requirement for us to do this. But all in all, looking forward, I think the digitalization is actually one of the points also which is very important. Beyond the culture right now, digitalization for me, I think the key aspect is really reducing the burden of extracting this kind of data, and it makes it more and more easy to do. So up until now, you would say, well, for me to do this, I would have to have a very complex registry, and then there is a very pain point for each individual physician or pharmacist to start putting data in. And the more we have technology helping us to make this process seamless, where the doctor to patient interaction is mediated or has already the digital is not something which you put on top of it. It's in between that relation. It's capturing that information and in a more seamless way. I think we're moving forward more into this arena in order to, and it's going to be more and more easy to extract information. One of the points is really, using artificial intelligence basically to extract from, information which is scattered for instance, recognizing handwritten, patient charts, or making it, or for instance, extracting metadata from test labs or imaging labs. So this is kind of one of the key points. The other point, which I think is also a roadblock, but I think all in all, we're more and more finding ways which you can really, open up these possibilities. Really, how can we address the interoperability? So creating standards for data exchange. I think the more we're going into this area, the more we're going to see common standards in terms of, data architecture, but also exchange standards which provide, GPRD compliance, so data privacy compliance, that preserves patient information, and while still allowing this data to use for secondary purposes, uses like, for research or for healthcare resources or optimization. So basically, we're going to measure costs because we need them, but because we can now do it in a much more effective way than before. And that's quite a very simple statement to do. One of the, I would like to report here just a while ago, actually less than a week ago, during the German presidency, there was, and this is available also in the internet, so you can really search on the ScanBalt initiative, which is the clusters in the Nordics, and this is a mega cluster which incorporates the Baltics plus Scandinavia and Germany jointly together, and they basically created this forum where they discussed that data and the health data is key to develop this, to develop the the healthcare sector all across Europe, and it's and one of the key points is really to create this opportunity to leverage data in support of the future healthcare strategy in Europe, and also improve not only improve efficiency from the healthcare systems, but also as an opportunity to develop a cluster of health in Europe, which we lead, we're one of the leaders of the world. So, and this is one of my requests also to to everyone who's watching is really please log into this Canvas. I'm going to make this presentation available, where essentially you can look in what was the joint declaration. Portugal was one of the experts, one of the country experts, the Portuguese health cluster. They joined this declaration, and basically you can see exactly what is the aspiration to create this European health data space, where we basically share a common platform which can be shared all across Europe, while providing data to improve care processes, to improve research, while still protecting and addressing patient confidentiality. So this is one of the points that I really wanted to make to you. Please visit the website, take a look at the declaration and support. Moving forward, in the case of my specific case of Pharma, value-based healthcare is actually, we started most of the times and as a response for market access here in Portugal. One of the traditional areas that we look into, it was up until now very painful. We would look into very different databases, try to look into or doing specific research projects to understand really the disease, how was the treatment pattern before and after the innovation that we bring, and also the outcome. So and this is kind of my point here is really the more we have access in a way which is sustainable and ethical, we should be more and more working together to really when we bring innovation, that we have a clear proposal, value proposal to health authorities in terms of what is the disease, who is going to benefit from it, who are specific clusters of subpopulations who are going to need, will have more pressing need for that medication, and really how we see disease progression going on, understand really the care patterns and costs, and also really work jointly on how can we improve outcomes together with and this, the idea is really, if value-based becomes material, I think the aspiration is really, it's value-based is going to change the nature if we fully realize the promise is really that if we have the joint value definition between all the stakeholders, it's going to necessarily make the discussions more collaborative in the way that we are going to define what is an intervention and then how can we make the best use of it. And it's going to change the nature of our relationship between all the stakeholders, from research, because we can feed very early into the process more emphasis on medical needs which are still not met, but also when we discuss with payers or regulators on what is we can not only discuss what is the value of the medication, but how can we optimize the use of that medication in a way which really improves the outcomes of patients. And if this is true for pharma, I'm sure it's true for medical devices. I'm sure it's true also for heavy equipment, for all the suppliers in the healthcare chain. And I think this is probably one of the areas which is going to have a lot of transformation going in. And one of the, for instance, when we discuss about treating systems in the future, we might be discussing not just how we're going to use one specific medication, but rather how can together improve and reduce the burden of a disease, reduce hospitalization, or reduce the number of deaths or hospital admissions or whatever. So it's I think we're just starting to have these discussions, and the more we focus on outcomes, the better that relationship is going to be. And that is my final remarks. I will be available for for any question you want to ask.